Good afternoon, everyone. I'd like to welcome you to our AAST Grand Rounds today. It is co-sponsored by the Geriatrics Committee and the Prevention Committee of the AAST. First, a couple of housekeeping items. I would be remiss if I didn't acknowledge the significant efforts of Caitlin Sanders. She's a member Services and Education Coordinator at the AAST, and she's done so much to bring this webinar to you today. And I wanted to also mention that today's speakers do not have any conflicts of interest. And of note, CME credit is not offered for this live stream Grand Rounds. However, it may be offered for the archived versions of Grand Rounds. And so I urge you all to go to the AAST website after this was finished and download the sign-in sheet and follow the instructions so that you would be able to view the archived version and possibly claim CME at that time. So today's topic is one that is, I'm sure, of interest to all adult trauma centers and those trauma surgeons and other support staff that care for injured patients. And the title is Fulfilling Geriatric Patient Standards from the ACS Trauma VRC, also called the Gray Book, and Improving Outcomes for Geriatric Patients Using TQIP Data. And we have three very knowledgeable speakers today, and I'm going to ask that you put all of your questions in the Q&A as we go on. So without further ado, I'm going to introduce Dr. Melissa Hornor. She's an assistant professor of surgery at Loyola University Medical Center, and she's going to describe the standards of the Gray Book and also the important components. So thank you, Dr. Hornor.
Thank you, Dr. Kuhls. So my presentation is on the actual geriatric care standards within the ACS Trauma Verification or VRC handbook. So I'm going to go over what exactly is the VRC, why geriatric standards of care within the VRC matter, and then learn the exact requirements pertaining to geriatric care contained within the VRC required for trauma verification, and then understand a little bit about the evidence base behind the requirements. So the VRC stands for the Trauma Verification and Review Committee at ACS, and this is how you become an ACS verified trauma center. Their resources for the optimal care of the injured patient, or the Gray Book, define the standards of care that's required for ACS verified trauma centers. The Gray Book is publicly available at the link through this QR code. Myself and the other speakers today will also be referring frequently back to the best practice guidelines that were recently published by the ACS that pertain to geriatric trauma management. This is a very useful resource that is also publicly available at this QR code is a link. And this is a PDF handbook that has all the best practices for geriatric trauma patients, going all the way from trauma triage for geriatric patients, talking about frailty and comorbidities, how to screen for and manage those, medication management, inpatient, patient-centered care, and then all the way to post-acute care and rehab. So why are geriatric standards of care important in trauma? Well, as our trauma population ages, we're seeing more and more trauma patients over age 65. We're now greater than 30% of trauma patients are aged over 65. These patients aren't just older versions of younger trauma patients. They often present differently with unique physiology and risks. They respond differently to injury and face higher risks of morbidity, mortality, functional decline, and loss of independence, even from low mechanism injuries like a fall from standing. It's important to treat these patients differently than younger patients. They're more vulnerable to injury from lower intensity mechanisms, and when they do have high velocity mechanisms, they can get very severely injured. So it's important with seriously injured patients to screen for geriatric vulnerabilities, and then to use that information to optimize the vulnerabilities while they're undergoing treatment for their injuries. In the background of all of this, it is imperative to assess the healthcare goals for the severely injured older patient and ensure they are receiving the care they would have wanted to receive. So now we will get into how the VRC is working to ensure that geriatric trauma patients receive this specialized care. So in the resources for the optimal care of the injured patient, there are two main standards that refer to geriatric care. This is the first standard about it referring to a geriatric provider liaison. I will discuss this more in detail, but this is the standard pasted exactly from the book. And then this is the second standard that I'm going to discuss throughout the presentation, where this is a care protocol for the injured older adult, and this is divided into 7 different components. I've distilled it into this talk into 5 components that I will discuss in detail throughout the presentation. So notice that this standard is a type 2 standard. I'm just going to discuss briefly what exactly that means in terms of trauma verification. So type 2 standards are enforced slightly less strictly than type 1 standards. So a trauma center can be non-compliant with up to 3 type 2 standards and still be considered a verified trauma center for 1 year. And then the trauma center will have to undergo a re-review and show that they have complied with the standard in order to get re-verified. So it is mandatory, but a little less strict than the type 1 standards. So now to drill down deep into the exact standards within the VRC gradebook. So as for the geriatric liaison, this could be a geriatrician, or could be a physician with the expertise and a focus in geriatrics, or an advanced practice provider that has a specific certification in geriatrics. So the role of the liaison is to basically assist in the development and implementation of geriatric protocols that are described in the other standard, and to just be available for patient consultation when you have a geriatric patient that's injured. This standard is fulfilled differently by each center, kind of depending on your local resources, whether you have a geriatrician available, and it's different at each unique center. Now for the care protocols, and I divided this into 5 different components. So the first one, there are geriatric vulnerabilities that trauma centers must screen for to optimally care for the injured geriatric patient. So per the VRC, there are mandatory screening tools that identify patients that are vulnerable or who will benefit from the input of a healthcare provider with geriatric expertise. They specifically outline screening for dementia, depression, delirium, and mobility limitations. So one way to screen for all of those things is a hot topic that I'm sure everyone on this webinar is well aware of, frailty. So frailty kind of encompasses all those things. It's defined as a state of decreased physiologic reserve that results in an increased vulnerability to stressors like surgery and trauma. So frailty assessment has emerged as the most reliable form of measuring an older adult's likelihood for adverse post-trauma outcomes. So frail patients are more than twice as likely to experience in-hospital complications and discharge to skilled nursing facility, among other poor outcomes. So how do you screen for frailty? So here's one way to screen for frailty: the Trauma-Specific Frailty Index, which is validated in the trauma population. And I'll talk about a multi-institutional trial that studied this frailty index and the outcomes of trauma patients in relationship to this index. So this index is 15 components, and then you basically assess all 15 components and divide by 15 to get your score. So the highest score is a 1, and then frailty is actually defined as greater than 0.25. Here's another way to screen for frailty. This is a more simplified but also validated version of a frailty screening tool. This is actually one that we use at my center. It's a acronym for FRAIL and just involves these 5 questions involving fatigue, resistance, aerobic capacity, comorbid illnesses, and then weight loss. So why is important to screen for things like frailty? Well, multiple studies have confirmed that frailty has negative impacts on outcomes after trauma. This multi-institutional trial confirmed that using the trauma-specific frailty index, that every 0.1 increase, or just like one of those 15 items, was independently associated with increased mortality, major complications, readmissions, and fall recurrence. So as a patient gets more frail, their worse outcomes get more likely. So onto the second aspect of the VRC Gray Book requirements for geriatric care. There must be inpatient geriatric specific protocols that are used for these highly vulnerable patients that you identified. So for dementia or delirium, they suggest multi-component delirium prevention protocols, and then they also require assurance of early, frequent, and safe mobility, which could be contained within a delirium prevention protocol. So these protocols involve multidisciplinary care and involve other disciplines like geriatrics, pharmacy, physical therapy, occupational therapy, social work, and palliative care. Here is one example in the literature of a frailty care pathway used for trauma patients. So involved a delirium prevention pathway, mobility pathway, ensuring goals of care were also collected for the patient, and then involving injury prevention with fall prevention education for patient. So frailty care pathways are about avoiding additional harm to the patient that could result from their vulnerabilities, like harms that could result from disrupting their sleep cycle and not letting them get the rest they need, by drawing labs in the middle of the night or getting vitals that aren't needed in the middle of the night, making sure they have their vision and hearing aids, and then making sure they get out of bed frequently so to avoid pressure injuries and just avoid general deconditioning. So these frailty care pathways have been shown to improve outcomes in multiple studies, but this study in particular used the frailty care pathway, looked at it pre and post intervention, and found that post intervention, even after risk adjustment, patients had a lower delirium and 30-day readmission rates, the frail patients that did get the pathway care. The next requirement from the VRC Gray Book is to document healthcare goals, which we can all agree is a great thing to do for any geriatric patient, but especially one that has been susceptible to injury and is coming in with a injury that needs to be managed inpatient. The specific items that you have to collect to stay compliant with the VRC Gray Book are the healthcare preferences and goals of care, get a code status for the patient, advanced directives to collect those and make sure that they're available in the medical record, and then also identify a proxy decision maker just in case they're not able to make decisions on their own. This can be easier said than done, especially in severely injured trauma patients that come in with no warning on short time horizons and need emergent interventions, and you don't have time to discuss with and identify with family members. Here are some tools that are recommended by the ACS Geriatric Trauma Management Guidelines that I discussed earlier. These things can be helpful in these difficult situations, especially these high stakes surgical decisions for patients that are in high likelihood of bad outcomes after surgery. The fourth component of the VRC Gray Book Geriatric Standards is medication management, just making sure appropriate medication reconciliation is done for their home medications, and then avoiding inappropriate medications that could cause geriatric complications. Resource for this is the AGS Beers criteria, the American Geriatric Society Beers criteria, which is a very long list of medications that may be inappropriate for geriatric patients. This box 8 here is a handy more specified inappropriate medication list from the AGS Beers criteria that is available in the ACS Geriatric Trauma Management Guidelines. And these are ones that can be related to falls and can also be inappropriate in geriatric patients to watch out for. The fifth and last component of the geriatric standards is just ensuring safe transitions out of the hospital. This obviously is important for geriatric patients that have multiple consultants to follow up with and who might be getting discharged to somewhere other than home. This is important, especially in frail geriatric patients. This study found that frail geriatric patients are actually at a 49% higher odds of readmission after ground level falls. So hospital discharge planning for frail older people can be improved with better communication with and better education with the family, and then coordinating recommendations among consultants and providing very close follow-up with trauma and primary care providers and other consultants after discharge. So in summary, my 3 take-home messages are: the VRC Gray Book has very extensive geriatric requirements. Some of the standards are a little flexible and up to the interpretation of the center. But I think that these, if these are done by the center, it will greatly elevate the care that geriatric trauma patients receive, because this is a subpopulation that really benefits from additional geriatric vulnerability screenings and from multidisciplinary care protocols. Thank you, and just wanted to highlight one last time those geriatric trauma management guidelines. If you missed it before, here's another link to these guidelines available online. All right, now stop sharing my screen.
Great. Thank you so much, Dr. Hornor. And again, just as a reminder for everyone to put your questions in the Q&A as well. Our next speaker is Dr. Carlos Palacio. He is Trauma Medical Director in South Texas at the South Texas Health System in McAllen, Texas. And he's going to be talking to us today about starting a new geriatric trauma program and many other aspects of starting a new program. So Dr. Palacio, it's all yours.
Thank you so much, Dr. Kuhls. Thank you for the Geriatric Committee, or to the Geriatric Committee, for the invite for this grand round. I have no disclosures, and I'm just going to emphasize some of what Melissa have discussed before. Basically, these are the 2 main resources that you have to look when you're going to start your geriatric program. So the majority of this talk is going to be based on these 2 resources. One is the Gray Book, as she already mentioned, and the other one is the Geriatric Trauma Guidelines, best practice guidelines that were released a couple of years ago by the college. Similar to what Melissa mentioned, before you start your trauma program, you have to know your rules of engagement. And I'm going to emphasize some of what she has already mentioned. So if you go to the book, numeral 4.5 or standard 4.5 is the one that refers to adding your liaison to the geriatric provider. If you guys remember, in the Orange Book, right before this one was released, geriatric was not part of this liaison, so it was added. Most importantly, it also describes the characteristic of that person, and as we have said before, it can be a geriatrician or it can be a physician with some expertise that focus on geriatrics. Or it can also be an APP. And if you remember, if this is for level 1s and level 2 trauma centers, so the majority of level 2, it's kind of difficult to recruit a geriatrician. So we have to lean into the either internal medicine physician with that expertise or an APP that will be able to take care of these patients. Similar to what Melissa mentioned, we also have to be in charge of developing the geriatric protocols, and that is what it's important in this particular case. We're going to talk. I'm not going to go in depth on the protocols, but I'm going to give you some hints that I learned over the last couple of years during survey. And then, as we mentioned before, you have to give the documentation or provide the documentation to the college as regards of the roles of the liaisons and the helps, as well as the evidence of board certification and eligibility. So with this, how do you do it? How do you get there? And there is no clear answer to the best way to develop or the best model of care to give to these older trauma patients. So I like this review paper because it described the different models that are out there to take care of the patients. And they have this nice figure in which they describe, they investigated the 5 types of care for the geriatric patient. And the first one is the centralized trauma management. So basically, the trauma surgeons admit patient and they deliver the care of for the elderly patient. It can also happen in a way of co-management. So in that particular scenario, so both the trauma team as well as the physicians are the ones that deliver the care for the patient. You can also have a consultation service in which either trauma or geriatrics admit patient and then they consult the subspecialties. Or if you don't have as many resources, you can develop the protocols and the healthcare providers will adhere to those and you will have to follow those through your PIPS program. You can also have alert and triage systems in which there is early warnings and triggers for the elder or high-risk patient. The article also mentions that it could be a combination of all of them. Now, there is, as I said before, there is no universal way to develop these models of care. Here in the US, I'm gonna pick up this model. One of my co-speakers was also the author of this one. And this is a retrospective study that was done in Houston, and it compared the outcomes of the patients when they are admitted to a geriatric trauma or to a geriatric trauma hospitalist service. So it's 2 services admitting the patient, and then they went ahead and compared both of the results. They excluded some sick patients, as you can see by the graph, but then after developing those protocols for admission criteria to either geriatric trauma hospital service or the trauma service, then the primary outcome was increased mortality. And even though both demonstrated decreased mortality, the length of stay was higher or longer, prolonged in the geriatric trauma hospital service. Now, this is a level 1 trauma center that had countless or at least 10,000 trauma admissions a year. So they're pretty busy. What about your level 1 or your level 2 that is not able to recruit a geriatrician, or that level 2 that can only get a hospitalist service that has that expertise? So this same article provide that education on how to onboard a physician. And in that institution, they require ATLS certification. They also develop a geriatric trauma certificate course. They have 13-hour lectures that are just focused on trauma-related topics. And of course, you have to complete 12 hours of CME that are related to the care of the elderly patient. Those include DVT, pre-hospital cardiac and pulmonary optimization, and postoperative complications, including delirium and management. So if you're not able to recruit a geriatrician, there are some resources out there, and I kind of like they describe in their paper the education they gave to those geriatricians. This is, as I think by now you know, that we have an emphasis in the protocols that we're going to develop for this elderly patients. And I have highlighted or bold, similar to what Melissa did, what are those 7 criteria that we need in that protocol? It's very important for us to go one by one so that you will be able to demonstrate to the verification review committee that you don't receive this type 2. You have also resources in the book, but I'm going to refer, of course, to the geriatric trauma management guidelines. I'm not going to go in depth into the physiology or the clinical aspect of it. I'm just going to briefly going to mention which ones are those 7, and that very important that you add it to your protocols. One of them is how you identify that vulnerable population, and that's why they endorse the geriatric trauma activation criteria. You have those 7 bullets that should be embedded in your trauma center activation criteria, and this should be monitored for compliance. As we know, injury mechanism and vital signs do not reliable triage older adult patients. Therefore, we have to introduce these solutions for under triage. I like also this review article. It actually came from the geriatric committee. The authors not only endorsed development of these triage guidelines within your hospital, but they take it a step further, and they also endorse the development of these guidelines in the pre-hospital setting as well as your regions. Sometimes the approach that we have to take is not only at our center, but also in our regions through the pre-hospital committee. Frailty score, Melissa did a great presentation about it. It needs to be embedded in your protocols. It's the only way you're going to be able to identify those patients that are going to require the input of that geriatric expertise. This is the same chart as we spoke before, 15 variable trauma specific frailty index, 15 variables. It's simple to use, trauma specific, and it's also tied to delirium and other markers that are important for the care of the patient. In addition to that, it does not require the assessment of some variables that are kind of difficult to assess in the geriatric patients, such as gait, speed, hand grip, or strength. Very important. I think on my last survey, this was something that my reviewers really pay attention to it. So if there is something I want you to take care or at least learn during this lecture, is your goals directive. That is very important that they're captured and they're documented. That's what the VRC wants to see. We have to have that goals of care conversations with the families, and those we have to set the tone for the families, making sure that it's gonna take some time for them to process what his loved one is about to go. Those conversations and improving our communication skills, it's probably the most important aspect of this bullet point that we're trying to show you. So make sure you document if you have that conversation with those family members. Make sure that it's in your chart and it's documented. Be, of course, cognizant of some cultural differences. Some cultures are not ready for that goals of care conversation, so give them a little bit of time to process and to realize. Something that has helped me personally is sit down with them, talk to the wife, then I have to talk to the sons, the daughters, and then at the end we have to be all together. Some families are different than other ones. Some ones are ready to continue doing the work together, but some of them can be challenging because you have 7 opinions or 8 opinions on how the patient would like to proceed. So improve your communication skills as possible and document it in your chart. Medication management, as we already spoke, very important, your pain assessment as well as your anticoagulation reversal management. Very important also to discuss your medication reconciliation in this stage where almost every single center has EMR in their hospitals. It's very easy to do the medication reconciliation, but we also have to have that discussions with the family as far as what is the patient taking. And finally, of course, is the implementation of safe transitions to home or other facilities. Very important, as Melissa mentioned, we have to assess the risk of falling for these patients, because sometimes we tend to send them home and then they come back very quickly to the hospital. Again, we're endorsing the best practice guidelines for the geriatric trauma management so that you are in track and you don't get a type 2 deficiency. So the protocols are very important. If you really want to take a step further and upgrade your geriatric care, so the ACS also has the Geriatric Surgery Verification Program. It's a program that was released back in 2019. And I understand it's going to be very difficult to sell to the administrators. Why do we have to spend money on this verification review committee in the geriatric surgery verification if I already had to pay the ACS? However, if you want to make the case, this actually a paper that was released a couple of years ago, it makes the financial case for that geriatric verification program. And they have a nice table that I think it will help discuss with the C-suite the importance. You're going to have a decreased length of stay. You have a decreased postoperative delirium. You have a decreased rate of admission. And most important, marketing. For them. It's just how do you sell? How is my trauma center different from other trauma centers in the region? And you can convince them by basically telling them, well, we provide excellent geriatric care through the geriatric verification program of the American College of Surgeons. I would like to endorse also the American Geriatric Society website. It has a lot of resources for your program, especially that component of education. Those centers that have difficulty recruiting a geriatrician, please refer to the website because it has a lot of CMEs that you will have to standardize for all the physicians taking care of the trauma elderly patient. And with that, Dr. Kuhls, thank you so much, and I'll take any questions at the end.
Great. Thank you so much for this really insightful talk. And I'm really happy to introduce our final speaker, and that is Dr. Sasha Adams. And she's a professor in the Division of Acute Care Surgery at McGovern Medical School, which is part of UT Health in Houston, Texas. She's also a trauma and critical care surgeon at the Red Duke Trauma Institute. And without further ado, Dr. Adams, great, turn it over to you.
Thank you. Just trying to get it to switch over. There we go. All right. So thank you very much. And as Dr. Kuhls mentioned, I'm going to kind of go the next step now, which is you've looked at the standards, you've set up your program, and now you're trying to figure out how to maintain it. And one of the things that you have at your disposal there is the TQIP data. You can use that to help pick your projects and improve the care you're providing. So of course, as we've already mentioned, this is all based on the ACS standards for trauma centers. This is the verification review for excellence in all these centers. And it's part of a very large quality program of the American College of Surgeons. Good to advance. There we go. So in fact, the American College of Surgeons has multiple quality programs across multiple surgical specialties, much more even than I have listed here. Many of the verification standards are actually also accompanied by quality improvement programs, and these collect data from each of the participating centers and then track and compare those to provide feedback to the individual institutions to help them do those projects. So Verified Trauma Center has the Trauma Quality Improvement Project. So TQIP actually focuses on specifically evaluating data from every trauma center that's participating around the country, and then gives those characteristics and comparisons to help you figure out which of the standards from the grade book you need to work on, which ones you are meeting qualifications, and which ones need additional work. The report is very robust. It can be probably overwhelming the first couple of times you get it. I would think, because it's quite a lot in there and quite a lot of information that you're going to sit there and try to get through. 42 tables at least included with multiple figures as well. I've just listed some of the big topics here, but there's also an individual table for almost every one of these measurement standards. They also break them up into your individual cohorts and then talk about individual outcomes, things like I have on the far right. Now, for what we're talking about today, the main ones that we're going to be paying attention to are the ones that are specifically the geriatric trauma or elder trauma cohorts, which are the bottom four: elderly, blunt system elderly, low injury severity, frail traumas, and then the isolated hip fractures. So how do you take all that information and then try to figure out what to do for your own institution? Well, first thing you're going to figure out is, where are you as an institution in a high outlier position? So then that's the thing you want to work on. So this report is going to give you a number of bits of information. You'll get a Caterpillar figure. It's going to compare odds ratios for a specific outcome: mortality, length of stay, severe morbidity, things like that. And it's going to compare your institution to other institutions across the country. This is a lot of this is going to be based on the observed versus the expected ratio for whatever that specific topic is going to be. You're also going to get your data in a quartile report. So you're going to have a format where you're going to have risk-adjusted outcomes here. It's going to show the decile of performance for your program, which is going to be there in black, amongst all the others. Green is good. It is the lowest decile. You're in the top 10%, for example. The red on the top is going to be a worse performance. It's going to be along with 90 other percent, for example. So if you're looking at something along the lines of mortality after, say, a ground level fall, you want to make sure you have the lowest odds of that happening in your hospital compared to the others. And they'll break it down for you as well with each of these deciles, and you can sit there and stew through your information and figure out what it is you need to do. So as Dr. Palacio mentioned, the Geriatric Trauma Hospitalist Service we developed in Houston. So he mentioned that. But this was just one of the lasting results that were developed from our TQIP guided program improvement projects. And I wanted to tell you a little bit more about how we did all this. So in fall of 2018, our TQIP report comes back, and we were faced with some pretty low performance areas in our program, specifically with our risk-adjusted mortality in our elderly patients. And this was something that we had already been putting a lot of work into, right? So we had already been doing some education, and we had already been doing nursing orientation. And we had some very focused faculty members who were champions of this within our institution. And then also, despite having very, top deciles in all of our other non-elderly patient outcomes, these three specific ones revealed that we had something we needed to work on. So we were starting at the 7th decile in elderly patient outcomes, and then the 10th for both elderly blunt multisystem and isolated hip fractures. So this started, of course, a lot of introspection and discussion, and of course, eventually action. So we created first a geriatric trauma task force. This was made up of multiple stakeholders across our institution. In addition to our trauma surgeons, it also with orthopedics, many of the other subspecialties, but orthopedics being the main one. We had our emergency medicine physicians, hospitalists, anesthesia. Our anesthesia works in smaller groups, so it's our trauma anesthesia and orthopedic anesthesia group specifically. Geriatrics, nursing, pharmacy, also had our respiratory therapists, physical therapists, occupational, speech, and then dietitians. And in our discussions of all the things that we needed to work on in our review of our TQIP data, we started doing deep dive audits into these patients with the poor outcomes. We learned a couple of things. First one was that we did need to do a better job of documenting and identifying those baseline health concerns in our patients: comorbidities, polypharmacies, frailty, all of these things that were impacting our expected outcomes. Well, if you don't document that, then the observed to the expected is going to be erroneously high. So that was one of the things that we found. But we did also identify that there were groups of patients within our cohorts that had poor outcomes. One of the groups that we found very interesting was we had geriatric trauma patients that were being transferred to our institution from another hospital, meaning they did not go straight from scene to us, but they stopped somewhere else along the way. And that they were having poorer outcomes even when you matched them for various levels of injury severity. So there was something about that stepwise progression getting to us rather than coming straight to us that was changing the way that their care was being delivered and resulting in poor outcomes. So we targeted some research projects to investigate these clusters, identify errors or oversights that we could potentially work on. Hopefully our goal was to find something that we could change in what we were doing and change these outcomes. We did a number of things system-wide. We coordinated with our nursing leadership. We increased screening for frailty, malnutrition, functional disability. And we adjusted some of our existing nurse-based admission assessments around the hospital just to help identify this. So our screening mechanisms were integrated into our our admission processes. We also led multiple education sessions with physicians and nursing teams to improve awareness of what geriatric syndromes were and how to identify patients that were potentially frail and what some of the risk factors would be there and how that is related to poor outcomes. We also utilized our research capabilities as an institution to determine how to measure, assess, and intervene as early as possible. We created order admission sets within our EMR, adjusting medication doses on the preliminary options for ordering, adding delirium prevention protocols and parameters also. As we worked with our emergency medicine colleagues, we tried to figure out this problem of these transferring geriatric patients with the poor outcomes. And we're able to identify that these were actually related to an occult hypoperfusion rather than other parts of our care. So we partnered with them, created some new algorithms to help identify those that were in occult shock. So just to give you some information here, and this, of course, is also the reason why a lot of times when we look at geriatric patients, we're looking at different sets of normal vital sign parameters, right? So what we have here is the patients who are for sure in shock in red, and the probability of mortality or major complication went up with age. But the green ones, these were ones that were in occult hypoperfusion. They were identified as having normal-ish vital signs, normal by standard criteria, but they also had a base deficit of less than -2. And in those patients, they actually had higher rates of morbidity and major complication than even did our shock patients. So what we identified there was patients who needed a higher level of suspicion and intervention on arrival to identify those in occult hypoperfusion and actually treat them. They often had the same vital signs as the ones with normal or standard vital signs. So that the vital signs in themselves were not enough to identify them. We had to look at things like the base deficit. And then we also started using the point of care ultrasounds to help with volume assessments. And once we started doing that, we were able to impact some of those outcomes. Our stakeholder meetings continued. As everyone has mentioned, the geriatric trauma management recommendations and guidelines, the importance of having geriatric provider liaisons involved in the trauma service, whether that be a geriatrician, a physician with expertise in geriatrics, or an APPs with certification and focus. And so we also were discussing, how do we go about doing this at a different level, improving our care and improving that involvement of a geriatric expertise in our teams. And as Palacio mentioned, there's a lot of patients here. We have a lot high volume, and so it can be challenging and resource limiting to do this. So, we do, however, know there's a number of papers that have showed that experience and collaborations with specialists improves outcomes. This makes sense. We are the ones that are trained to do surgery. We are not trained to do geriatrics. That is what they trained for, and that is what they practice. But our patients are unique, and they need both of us to really have the optimal chance of recovery. So we considered the various ways that we could incorporate geriatric specialists. Who should admit them? Should it be our trauma team with the geriatric consult, or vice versa? Was it different for different patients? Maybe just sending some of the isolated injuries would go to the geriatrician or the hospitalist. And in fact, our hospitalist service was doing that already with some of the extremity orthopedic fractures. They were admitting, 20% sometimes of those patients that presented. Or do we keep them on ours and say, oh, we're going to take care of it ourselves and we'll have expertise and develop expertise within our teams? Well, that also depends on the makeup of your team and your comfort and availability to take care of the patients at all times, especially if you're trying to juggle trauma call, for example. Well, what about the nursing component? Shouldn't we have focused education for our nurses, improved surgical units, and have them in a unit that's geriatric trauma or geriatric surgical, just like we have a difference between surgical and medical nursing units. Focus the education, focus the screening, focus the protocols to help things like physical therapy frequency, dietitian assessments, things like that. What about the consultation protocols? Do you do just age-based? Like every time someone's over the age of 65, we're going to do a consultation? I don't know that there's enough geriatricians in the country for us to do that. And so I think we need a better solution than just depending on them in that fashion. So what we ended up doing was a combination of a number of these. We'd already had a specialized unit with age-related surgical nursing protocols. We definitely did not have the capacity to handle age-based consultations. We did not have enough geriatricians or hospitalists for that. So we've tried to create protocols for selective consultation, particularly in those with advanced frailty, multiple geriatric syndromes that are affecting their care. And probably the biggest difference has been made by integrating our team with some geriatric specialists, in particular hospitalists with geriatric training. This became a partnership. We actually hired 50% into our own department of surgery, hospitalists that, as Dr. Palacio mentioned, ATLS certified. They have specific CME guaranteed to expose them more than their typical CME to our trauma world and what we're discussing. They also come to our M&M. They come to our multidisciplinary committees. They are present at our every one of our educational committee meetings that we participate in as a trauma surgeons. So yes, it's 65 and older has been our admission guideline, but honestly, there's quite a few of those that we keep because they're fairly simple, and we try to direct only the more complicated patients over to that team. And they're often co-managed. We often have consultations rather than primary coverage. And the main thing is that it is a cooperative and venture across the board. Well, with all that work, we did actually have quite a bit of improvement over the next few years. We were able to improve to elderly trauma becoming the first decile, and then as well as the blunt multisystem, and then the isolated hip fracture. But it's a journey, not a destination, and often all the work you put in still needs more work to keep it going. So over the few years that followed that, we fell back down. We're back into the 8th decile for specifically isolated hip fracture mortality. And so, we're continuing to work on it. It was not over as it turned out. We have ongoing projects. Some of the things we have to do is go back and look, and well, we made all these protocols and we made such a big difference. Are we still adhering to those same guidelines that we set up before, or have we kind of slowly moved away from that? Is there been a change in service? Has there been a change in a process that we haven't accounted for, and we haven't identified how to readjust our best practices? And of course, because of the level of detail we have time to fixation in elderly hip fractures. So we can get down into the nitty-gritty of what is the average time before each one of these patients gets operated on. And all these things are what our current deep dive is to try to get back into those lower deciles where we have better outcomes. So your resources determines your plan. You have to figure out what your own institutional strengths are and your weaknesses, get your stakeholders together, and then figure out which gaps are unique to you and what structural support you can create to help make improvements. And just remember that the process and that collaboration that you create is actually the true measure of success, because that's the group that will continue to work on that moving forward. And every one of us, I'm sure, would agree that this trauma medical directorships, it's not just one person, it's a massive team, a lot of data collectors, a lot of trauma managers that really do the load of the work here and help us with this. So it's all about the team here and the collaboration. And with that, thank you very much.
Fantastic. Really 3 great talks on what are the standards, how to set up a geriatric trauma service, and how to maintain it, and to use the tools that were given largely from TQIP. And we're going to open it up now for question and answer. And I'm looking at the Q&A, and so the first question is, if a geriatric liaison is an advanced practice practitioner, do they need CME to be compliant? And I think that's a really, really good question. So I'm going to just open it up to the group, whoever feels confident to answer the question.
I'll defer if others know specifically, but I believe that every one of any of our designations, MD, APP, or nursing, requires continuous education documentation. You'd have to look specifically at what theirs are for practicing APP, but I don't believe that the recommendations had specific CME requirements for the APPs. It would be mostly dependent upon what their certification is at baseline.
Correct. It doesn't say that you need a specific or X number of CME. It's only mentioned you have to have the expertise. So you set the tone as trauma medical director as far as how many CMEs you want them to have per year, with the geriatric related to geriatrics.
That sounds good. So I just wanted to mention for everyone who's listening now that we've mentioned TQIP a number of times. So I just wanted to tell everyone that the TQIP conference this year is going to be November 8th through the 11th, and it's going to be in Chicago, Illinois. And that's actually a great venue to learn what other trauma centers are doing. So I don't have any other questions, but so sort of one question that's been posed to me is delirium obviously is a huge consideration in geriatric trauma patients. And while we try to prevent delirium, I'm curious if our speakers can comment on if delirium still occurs. Nonetheless, what have you found to be the best treatment other than, sort of doubling down on the recommendations for prevention?
I could take this one. So I think, it does definitely still occur, delirium, despite our best efforts in prevention. I try to emphasize non-pharmacologic care, so avoiding going right for Haldol, antipsychotics, unless they're really at risk of hurting themselves or others. And if they are just delirious but not at risk for hurting themselves or others, then really just reinforcing the good nursing care, which is just like keeping the lights on during the day, lights off at nights, reorient the patient, tell them where they are, try to minimize tethers to the patients, take out their Foley if you can, identify possible causes. So it could be they have a UTI or they're constipated or they have untreated pain. So it's unfortunately never a simple answer as to just one way to treat delirium. It's something that always involves a lot of effort and thought, but something I'm teaching the residents each time they come on service.
100%.
Always a good
100%
idea
agree.
to teach,
Yeah.
to teach the future leaders of our professions. So, Dr. Adams, did you want to add anything?
I was to say, I completely agree with everything Dr. Hornor said already. Adding to that, really emphasizing that they're getting the good sleep, which is what a lot of the delirium protocols have to do with. Remembering that appearance of being still with eyes closed does not equate to sleep, and the least disruptions and things, especially in an ICU setting, which is very difficult. But noise in the area, all those things that affect the quality of sleep are very important in these patients. So that is really the key, trying to prevent, but then treating it with, again, those same measures. And then if you have to resort to medications, yes, but.
Yes. So another question that has come to me is, since we have a lot of, many times we have a lot of comorbidities in our older trauma patients, how have you found best to identify patients who need like cardiac evaluation risk stratification. So I'd be curious criteria that that you found to be helpful.
That is an excellent question. In my institution, we actually have a consult to the CRNA, and they assess the risk. Sometimes it's not useful because they all go with high risk. Those patients, we do have a protocol after surgery to be observed either in an ICU or in a step down, depending on how comorbid it is and age and other criteria, if we consider that they are really high risks. Before I can tell you, my hospitalists were calling cardiology right and left, and that was delaying and not making my TQIP numbers with regards of hip fractures on the green side. So we had to change that, and that's, as Dr. Adams says, we kind of adapt to the resources that we have, and that's what we have here.
Agree completely. And another factor we had, again, every institution is different. You got to customize it to what you have. As I mentioned, our anesthesia works in teams. So the teams that was working specifically with the orthopedics, we ended up having them sit down with cardiology, with hospitalists, and with orthopedics and us. And we all came together with a plan of, you know, outside of significant cardiac disease and dysfunction, what was our screening plan and how are we going to do it? And how are we going to get it done in a way that was efficient? It even came down to making plans for if we did, when were we going to get an echo? And if so, when were we going to get it read? So we protocolized that even with our cardiology colleagues to make sure that if we had gone that route, it was prioritized to early so it wouldn't disrupt plans to get into the OR. And it's a work in progress, just like all the rest of them. We did really great for a long time. And then we had personnel changes and the plans didn't come through. So we're back on that again of trying to make sure that everybody's on board with having the same plan. It's the one person who's not on board that says, wait, no, I want an echo. And we're like, oh, but we didn't get one because we have a guideline and we followed it. And it's kind of that whole process of continually re-educating and reevaluating. Is this still the right plan? Do we need to change it based on our resources? So.
Great. So I would like to thank all of our participants and especially all of our speakers today. And we're glad that everyone joined us for the AAST Grand Rounds. And again, as a reminder, go onto the AAST website and download the sign-in sheet and follow the directions. And if CME becomes available, you'll be able to claim it at a later time when the archive version of this is available. So thank you again. And I also wanted to just extend a thank you to the leadership of both the geriatric and the prevention committees for collaborating on this Grand Rounds. Okay, good afternoon.